Welcome to the University of Arizona College of Medicine Phoenix online faculty development module, Outcomes-Based Education, Setting Expectations, Giving and Receiving Feedback. Contributing faculty and staff include Dr. Christine Savvy, Dr. Jennifer Alley, Dr. Jennifer Hartmark-Hill, and Jonathan Snyder. Learning objectives for this session include discuss approaches for setting clear expectations of a learner and teacher, describe successful methods for providing and soliciting feedback in an educational setting, and compare and contrast multiple methods of assessment. Let's begin by considering some evidence regarding the need for ongoing faculty development in giving feedback. Similar to national data, significant numbers of our medical students do not perceive that they receive adequate feedback. Less than half of our students reported receiving sufficient feedback during core clerkships. Less than 2/3 of students reported that their performance was assessed against the stated learning objectives. There are a few reasons for this, and we will help you learn how to avoid common pitfalls. In this module, we will explore ways to ensure clear expectations are set, to promote student understanding of how and when they will be assessed. We will also consider strategies for providing adequate feedback to students that is both timely and appropriate. Thirdly, we will encourage ongoing reflection by clinical teachers as to ways of continuous growth and improvement. We will share with you a number of tools that can be adapted and refined as you continue to work with learners and gain insight over the coming years. Beginning with setting expectations, let's review the various components of the clinical learning environment. The more both teacher and student are aware of the myriad dynamics, the more successfully the teacher-student dyad can become in navigating challenges, meeting goals, and building relationships. First, let's consider the academic institution. This will be the medical school or graduate medical education institution or residency in which medical students or residents, respectively, are enrolled. At the University of Arizona College of Medicine Phoenix, we utilize the same competency areas as residency programs as set forth by the American College of Graduate Medical Education, the ACGME. These include patient care, medical knowledge, professionalism, interpersonal communication skills, critical appraisal and quality improvement, also known as practice-based learning, societal awareness and responsiveness, or systems-based practice. However, we set expectations for and assess these competencies at a different level than do residency programs, as we will discuss later on. It is very important to be aware of institutional expectations, such as the competencies, when taking on a rotating medical student or resident. Not all competencies are expected to be demonstrated in the same way for various developmental learner levels. Therefore, if not provided to you at the beginning of a rotation, we recommend that you be proactive in requesting an institution's expectations of the learner specific to when that learner is in your clinical setting and under your guidance. This will help you to plan how you might approach teaching in a way that is both tailored to your setting and meeting expectations that are developmentally appropriate as set by an affiliated institution. While the competencies describe desirable characteristics of both practicing and future physicians, the educational program objectives provide descriptions of measurable outcomes to guide curriculum development. In this next segment, Dr. Jackie Chadwick, Vice Dean of the College of Medicine Phoenix, describes the importance of the educational program objectives and how they are used.
We, like other medical schools, start with a set of overarching educational objectives for those 4 years. In other words, what do we, as the University of Arizona College of Medicine Phoenix, state that we want every graduate of our college to have learned? These are called Educational Program Objectives, or EPOs. They can be found on our website. These EPOs govern every aspect of our curriculum, and they're based on the ACGME competencies. They include such things as patient care, medical knowledge, professionalism, and interpersonal communication skills. The list of individual EPOs would be intuitive to a practicing physician. We have 47 of them, and they include such things as obtain an accurate history and perform a complete physical, demonstrate knowledge of the molecular, cellular, and biochemical basis of homeostasis, elicit information using patient-centered listening skills, maintain a teachable attitude. Every single lecture, simulation activity, clerkship, and elective is linked and mapped to one or more of these 47 EPOs. At the end of the 4 years, we can see where and when each objective was taught. Additionally, each objective must be assessed. That is why we ask you as faculty to spend time in giving the students feedback, both to help them grow, but also to assess their acquisition of knowledge, skills, and behaviors. Bottom line, it's incredibly rewarding to teach the next generation of physicians. We, as the faculty of the College of Medicine Phoenix, take this seriously. We would encourage you to read through the EPOs, be prepared to understand your role in teaching them, and take seriously the role you play in assessing them. By doing this, we graduate the best prepared physicians, those who will take care of us and our loved ones.
As stated, the College of Medicine's curriculum strategically maps each competency area to our 47 educational program objectives. Our graduating medical students must demonstrate competency. From the first year forward, our students are assessed against the developmental milestones, which provide a trajectory towards successful competency in our educational program objectives by the time the MD degree is conferred. Our educational program objectives are on a continuum with next level entrustable professional activities, or EPAs, which resident physicians must master and maintain throughout their professional careers. The value of the APAs includes data for assessment of student performance and outcomes, a basis for ongoing feedback to students, and also provides data which is utilized by faculty and curricular leaders for ongoing quality improvement. In resident graduate medical education, entrustable professional activities are used, which are units of professional practice defined as tasks or responsibilities that trainees are entrusted to perform unsupervised once they have attained sufficient specific competence. EPAs are independently executable, observable, and measurable in their process and outcome, and therefore suitable for entrustment decisions. EPAs are what we expect a particular specialist to be able to do without supervision upon graduation from residency and fellowship. Competencies are descriptors of physicians, EPAs are descriptors of the work. As an example of how entrustable professional activities are mapped to the 6 competencies, consider the chart below. An academic program might use assessment of a resident or fellow's ability to execute a thorough and safe patient handover on domains of medical knowledge, abbreviated as MK, patient care or PC, interpersonal skills and communication or ISC, and systems-based practice in terms of ability to navigate the hospital or other relevant clinical systems. A program could elect to evaluate patient care transition on the basis of professionalism, or in this example, defer formal assessment of professionalism to chairing an interprofessional meeting, or a number of other duties. Knowledge of which competency a program wishes to be assessed for a given clinical setting and scenario will provide you with an important framework for how the learner should be given expectations, taught, and provided feedback. Let's look at a few specific ways competencies might be assessed at various learner levels. This assessment form serves as an example of how a residency program might assess the competency area of patient care, specifically with the subcompetency of history gathering skills. Assessment descriptors might range from Level 1, that the resident either gathers too little information or too exhaustively gathers information, meaning they are not able to determine an appropriate focus history and delineate which information is important. Level 5 illustrates the ideal version, that of a robust illness script leading to a seamless, skilled gathering of accurate information. Level 3 might represent a desired skill level by an intern in their first year of the program. Level 4 might represent a desired skill level by a more advanced second-year resident. Level 5 would represent a desired and consistently demonstratable skill level by a senior resident who will soon be an attending physician. While Level 2 might be suboptimal for a resident, a third-year medical student might be meeting or exceeding expectations for their level if demonstrating the described behaviors. Likewise, a high-performing fourth-year medical student completing a sub-internship might be able to achieve a similar level or within range of an early intern. So you can see that this assessment scale really can be taken on a spectrum of learner levels and competencies through which medical students and residents must progress. No longer is it adequate to simply complete a rotation, or even to see one, do one, teach one, without meeting specified milestones and competencies. Outcomes, rather than process, are emphasized in current medical education. Here is a real example of a portion of an assessment form used for College of Medicine Phoenix clerkship students. The same competency of patient care and subcomponent of history gathering skills is examined. Our assessment utilizes 3 levels: exceeds expectations, meets expectations, and does not meet expectations. Rather than leaving the expectations open for interpretation and subjectivity, we follow good practices of defining what is expected. If working with a third-year medical student, joint review of this type of assessment form provided by a clerkship director will set a strong foundation for shared expectations between preceptor and student. Similarly, the assessment for pre-clerkship students in their first and second years of medical school is scaled back even further to reflect the developmental nature of the curriculum. The example forms just reviewed demonstrate unique expectations of a course, clerkship, or resident rotation, but keep in mind that all are mapped back to institutional expectations regarding educational program objectives, EPOs, and entrustable professional activities, EPAs. Thusly, creating your own reminder checklist of expectations to review with a learner might look something like this. Your clinical practice itself will have its own expectations that are important to review with a learner. An example checklist that could be created to be given to the learner and discussed might look something like this. This type of checklist can also be delegated to a medical education coordinator if available, or a team member. Logistical information such as this is often provided in written form to a learner prior to a rotation. The community in which the practice exists is another layer of orientation for a learner, especially when a learner is from an out-of-town program and is unfamiliar with important relevant community and patient demographics. You can also provide this information in written form. However, if one of your goals is to inspire a student or resident to consider a career in your setting, sharing the highlights in person regarding what you love about practicing in your community can leave a lasting positive impression. In addition to sharing population demographics in your community for and with a learner, setting expectations with individual patients regarding a learner is also good practice. Here is an example notice that can be posted in patient waiting areas. Some practices who have learners for a month or longer will even provide a brochure with the learner's brief biosketch. Patients often view academic teaching as a positive sign that a practice is up to date, collaborating with a respected medical school, and paying it forward to future generations. Patients feel respected when their contributions are acknowledged, as long as the overall approach is patient-centered and for the bigger picture purpose of better patient care. Setting expectations is important to creating a conducive environment and culture, but should not take the place of showing deference and respect for patient preferences in their own care. It is still a good idea to have a healthcare team member ask the patient if it is okay that they be seen by a learner in addition to their doctor, without the physician or learner present, in order to not place undue pressure on the patient. Staff can be trained to message the request in a positive manner, such as, "This way you will get additional team members involved in your care," reassuring the patient that they will be seen by their doctor after a learner asks a few initial questions plus or minus a physical exam, depending on the level of the learner, goes a long way to letting the patient know they will still get the same level of quality care from the physician. The preceptor and clinical team the learner will be working with provide another consideration in setting expectations. Here is an example checklist. Consider what you might go over with a learner for your team to help promote successful interactions. Lastly, but not least, is the opportunity to set expectations at the level of the learner themselves. Here is an example form you could give to a clerkship student when you first meet them in order to learn more about them. This information will help you to provide context for their developmental level, interests, and motivations. Similar to utilizing motivational interviewing skills with patients to encourage positive outcomes, learning what your students value and what their background is will help you enhance the teaching opportunities and professional relationships you will have with each learner. Finally, set expectations with regard to feedback. How much, when, and what type. Discussing and setting expectations for feedback can consist of when the learner can expect to receive feedback. Will this be at the end of each half day or at the end of each day? You can also let them know you welcome feedback. Creating a safe learning environment of mutual respect and value will also allow a learner to be comfortable to share feedback that can help you adapt and grow as a preceptor. Consider asking learners questions such as, what has been your experience with receiving feedback in the past? How do you prefer to receive feedback? From there, you can set shared expectations for when and how feedback will occur. This conversation will also serve as a strong signal to students that feedback is valuable and that they will be receiving this from you. Types of feedback can be informal or formal. Feedback can be given informally at the end of a clinic day or hospital shift, or scheduled formally as a mid and end rotation review. Types of feedback also include formative and summative. Formative feedback is narrative and/or written, offers suggestions for improvement, and is for the purpose of monitoring student learning. Summative feedback compares students against a benchmark of success, for example, test scores. Best practices include providing both formative and summative types of assessment to provide a wider range of feedback learning opportunities. An example of both in clerkship years includes verbal and written feedback given to students by preceptors during a rotation, as well as shelf board exam scores for assessment purposes. Let's take a closer look at validated models for giving feedback. The W3 model includes the following components. What worked well? For example, you communicate clearly and in a manner that patients can understand. Well done. W2 stands for what did not work well. However, I noticed that the information recorded for history taking is too exhaustive. What could be done differently next time? Be sure to document what is relevant and pertinent to developing a treatment plan and omit details that are not patient-related. Best practices for providing feedback include following the stated expectations of a learner over your gut feeling about them, evaluating based on evidence, separating observation from judgment, comparing observed performance to stated expectations and not to other observers or learners, and reviewing milestones and expectations. Another model is the ASK model. In this model, you want to ask a student to explain why they demonstrated behaviors you found questionable or did not complete or attempt an action or behavior. Ask questions to explore further, or ask students to provide a SMART goal. Acknowledge and suggest areas for improvement in relation to student explanation of behaviors. If the student is unable to, help them to formulate a SMART goal, which is specific, measurable, attainable, realistic, and timely, and includes details of when, where, how, with whom, and how many times. Confirm student understanding and commitment to specific strategies, and hold students accountable in the next encounter for the goals they have set. Let's look at some scenarios with teachable moments. In the upcoming video clip, Vicki is a first-year medical student, giving Dr. Morgan the history and physical of her standardized patient. She is confident that she has covered all the required aspects but has missed some obvious areas. Her communication skills are also questionable as she presents an overconfidence in her knowledge in terms of both the procedures and findings.
Come in.
Hi.
I'm Dr. Goodella.
Mandy, nice to meet you. So I'm a third-year student here, and I have a patient with CHF to present to you.
Okay.
So this is a 45-year-old Russian male. He comes in for follow-up of his echo, which he got done originally for worsened shortness of breath. And I saw that you started him on 40 mg of Lasix, which, fine, but I think right now the best thing to do would be to add digoxin. I read in a New England Journal of Medicine study that adding dig helped a lot of CHF patients. So we can get him started on that, follow him up in 2 weeks and see how he's doing. So.
Okay. Well, sounds great. So since this is our first time meeting,
Sure.
I'd like to get an idea of what you know about heart failure and the treatments for heart failure. I think it's great that you're reading. It sounds like you've got a good journal that you're reading out of, and it sounds like you're very proactive in your education. And so what I'd like to ask you is, did you examine the patient today?
Yeah, I examined him.
Okay, and what did you find?
So he has dyspnea and edema. Vital signs were 130/90, pulse was 90, pulse ox was 93, which, it's still in the 90s, so it's okay. Heard bibasilar rales and some crackles bilaterally as well. Noticed an S3, no JVD. And he's also insulin dependent. He's also an insulin dependent diabetic, but I didn't bother to talk to him about his diabetes or his insulin doses because he's here for a shortness of breath and his heart failure. So,
Using the ASK model, what could be Dr. Morgan's feedback to Vicki? Let's see what feedback Dr. Morgan is able to provide in this teaching opportunity.
Okay, so maybe we should go back and you should start with his underlying diagnoses, because why would that be important?
for his heart failure,
Mm-hmm.
well, given that he has heart failure, looking at signs and symptoms and what we can do to improve them, and the pathology behind it, and what is going wrong with his heart, and
Okay.
the
so-
consequences and complications. of it.
Good. Okay, so when we look at heart failure,
Mm-hmm.
what are some of the causes of heart failure?
So there is smoking as can be a risk factor. Obesity, his diet, high cholesterol.
Okay, and those are definitely risk factors for coronary artery disease,
Mhm.
but are there other things that you would consider for heart failure?
In another example, Samantha is a third-year medical student who has just seen a 16-year-old patient suffering from acute lower back pain. She presents to Dr. Morgan the findings, but is disorganized and having a difficult time staying focused.
I'm a second-year family practice resident, and I'm here to present my patient to you.
Okay.
Is that okay?
Yeah.
Sorry, I've been just running so late today. Things have just been so backed up.
Okay, before you start, I just need to tell you that I almost went in the room to find you because it was taking a little longer than I had expected, but then you came out right when I was ready to go in. But I do need to catch a plane today
Okay.
in about 20 minutes.
Okay, gosh, all right. So, so I have this patient. She came in with a runny nose, a sore throat, and it hurts to swallow. And on the exam, I just saw a little bit of erythema, but not really any tonsillar exudates or anything. And she said she hasn't had a fever, but I think her, let's see, I think her temperature was like, that's not it. I have her vitals around here somewhere.
That's okay.
Here it is. So her temperature was just 99. So she's afebrile, but then she's also concerned because she thinks that her son was exposed to strep throat, and apparently she's been under a lot of stress because her son's teacher thinks
Okay,
that.
so Katie, I'm going to stop you.
Using the ASK model, What could be Dr. Morgan's feedback to Samantha?
I'm sorry, normally we have more time to do this, but we've talked about me having to get going, and I want to make sure we take good care of the patients.
Okay.
Have you had any feedback on your presentation style?
Yeah, I mean, I've had some. Sorry, excuse me.
Okay.
Sorry, I just have to take this. Hi. Hi, Grandma.
So,
I'm so sorry, Grandma. I know your cat needs her pill, but I'm gonna have to call you. I have to go. Okay, bye. Sorry about
So
that.
that's okay. So what we need to do today is to take care of the patient, and we need to talk a little bit, maybe we can make a separate meeting, but we do need to talk a little bit about your organizational skills, because I think
Okay.
that probably the most important thing we need to focus on today is not so much the differential of a sore throat or this patient's symptoms, but we need to focus on a little bit on your organizational skills and efficiency.
Okay.
So we'll take care of this patient.
Okay.
But I need to ask you quickly, is there something that that you feel that you need to work on?
Well, I've just been running really late today. I don't know.
All right, so what we should do is set up a different time, a separate time, because I really do want to address the issues of efficiency and organizational skills.
Timeliness of feedback is essential to changing behaviors. Receiving written feedback on a deficit after a rotation has ended, when nothing was communicated to the student more proximal to the time the behavior was observed, can lead to learner frustration. The learner also misses out on an opportunity to work on improvement. Additional recommendations to consider include establishing an appropriate interpersonal climate, using an appropriate location, establishing mutually agreed upon goals, eliciting the learner's thoughts and feelings, reflecting on observed behaviors, being non-judgmental, and offering helpful suggestions for improvement when giving feedback. Here are examples of real preceptor feedback that has been helpful because it includes both positive and constructive feedback. Student reads up on patients and proactively makes mini presentations on patient-specific topics for the team. He asks insightful questions. He knows his patients H&P thoroughly and also has great rapport with them and their families. No areas to work on at the moment. Student is progressing and communicating well with patients. However, continue to build differential diagnosis via patient learning. Try to refine physical examination in order to help guide diagnosis and management rather than an exercise in itself. Student is enthusiastic, eager, hard worker, and is obviously reading and engaged in the patients and their care. His presenting skills are improving. Continue to practice with colleagues. As a preceptor, when you receive feedback, try to keep an open mind. Even if you do not completely agree with the feedback, be open to using the opportunity for self-reflection and as an experience for growth and innovation. Take a look at these examples of real feedback from our medical students. My facilitator lets me know what I can do to fix something instead of letting me be mediocre. I appreciate that. I would have liked more feedback on how I can improve my clinical skills and patient-faculty interactions. As a new third-year medical student, I am still learning how to master skills such as assessment and plan, differential diagnosis, and oral presentations. I was very eager to learn which areas I am doing well in and areas that need improvement. I would have liked more specific feedback throughout the rotation so I could work on and improve those skills. Dr. X always went out of his way to offer specific feedback on patient encounters. It helps me to learn to do things the right way. I was in a wonderful teaching environment with a fantastic preceptor. I was given a ton of autonomy, seeing patients on my own first, then staffing with my preceptor and devising a plan, then going back in together, as well as doing many office procedures. Also, the hours are of course amazing, and the individual preceptors really strive to promote student engagement and learning. When providing feedback to learners, assess the strengths and problematic areas with equal weight. Remember, each feedback instance provides professional growth opportunities for both the clinical teacher and the learner. Sources of feedback that you might consider drawing upon to get additional perspective regarding your strengths and areas for improvement include your colleagues and patients. It is commonly difficult for people to ask for feedback, but it can be worth the effort in terms of the information gained.
Dr. Rock has just received his student evaluations for his past 4 rotations. The majority of student comments highlight his skill, compassion for his work, and communicating specific feedback to them in his teaching efforts.
Dr. Rock rocks. He's an excellent attending. He always knows how to tell me what's going on or what to do without leaving me feeling like I don't know anything. He's a great teacher, and I'm so glad I've had the time to get to work with him.
I've had the best experience working with Dr. Rock. His compassion shines through in everything he does and the kind way he works with patients. He attentively listens to everyone and offers nuggets of knowledge and insight in his responses. Truly amazing physician.
However, 2 of the 20 students he received feedback from indicated that they were often lost or unaware of what expectations were set for them.
Dr. Rock is a great physician. He is able to speak to patients in a kind manner and still have them listen to what they need to do. I just wish I knew what was expected of me when I'm with him. I don't receive much feedback, and when I do, it's not clear. I wish he would take the time to let me know what I needed to do.
Dr. Rock is a wonderful attending, someone I would like to learn more from. I just wish that I knew exactly what I needed to do. I'm often left standing aside just watching. If I knew what to do or expect, it would help me take more away from the rotation.
What should Dr. Rock take away from these responses? Considerations for Dr. Rock would be:
I'm flattered the students feel that I do well as a teacher in giving them feedback. I try and provide what I can so they learn and feel supported. It does concern me that 2 students indicated that expectations weren't clear when they first arrived. I realized most students didn't indicate this, but perhaps I could be clearer. One of my colleagues uses a checklist to set expectations that could be helpful to use.
Dr. Lincoln has just received her annual student evaluations for this past year. A few of the student comments indicated that they particularly appreciated Dr. Lincoln's attention to detailed feedback.
I appreciate the time Dr. Lincoln takes to give me specific feedback about my presentations. It's tough love, but at least I know I need to do better.
However, most of the other comments indicated that they thought her attention to detail was harshly delivered in a condescending manner, and that she offered no suggestions for improvement, just indicating what they did wrong.
Dr. Lincoln listens attentively to what I present, but she isn't the nicest when giving me feedback. She just tells me what I did wrong, but doesn't offer any suggestions of what I need to do better or how to fix it.
Dr. Lincoln is a great leader, and I appreciate her attention to detail. If she were able to give me feedback without leaving me feeling like a horrible person, I would be more receptive. If she were to stick to the facts and give me ideas of what to do to improve my presentations, it would help immensely.
What could Dr. Lincoln take away from these evals?
Considerations for Dr. Lincoln would be:
Wow, I didn't realize I came off this way. And I didn't realize I only focused on the negative and not the positive. If it were one student, it might be perception, but it's a majority of my evaluations. I thought I was doing a good thing by pointing out what students need to do better, but it's true that I don't give them suggestions or how to fix it. I've always struggled with giving feedback. It's not easy, especially in person. I wonder if there's a better way to approach this, or someone has any helpful hints, someone who also teaches.
Everyone has to start somewhere. Keep learning and innovating. We think you'll find that the experience brings great satisfaction and meaning to your career. In summary, giving and receiving feedback is essential for evolution and growth, and we have reviewed various tools for successfully setting expectations and giving and receiving feedback. Congratulations, you have successfully completed this module. Please see the assignment provided for you. And as always, we welcome your feedback. Thank you.